Hi, let's talk about the different types of edema and how they form. Edema means there is too much volume in tissue. The classic example is saltwater edema, which is excess sodium, chloride, and water in the interstitial space, so between the cells. But edema can also be fat or other substances. The first step is to determine whether the edema is generalized or bilateral versus local or unilateral. Generalized edema can occur in the legs, in the lungs or pleural cavity, around the eyes, which is called periorbital, or in the abdomen as ascites. Local edema, on the other hand, typically affects just one leg or one specific area. There are three main organs that typically cause symmetric or generalized saltwater edema: the heart, the kidneys, or the liver. Let's start with the heart. Chronic heart failure, and particularly heart failure with reduced ejection fraction, often initially leads to pulmonary edema and pleural effusion, causing dyspnea or difficulty breathing. But leg edema and ascites can also develop. Heart failure causes two main problems. First, there is forward failure, meaning the arteries chronically have too little arterial blood. The kidney becomes underperfused, leading to a drop in GFR, which activates the renin-angiotensin-aldosterone system, or RAS. If you want to learn more about the RAS, check out this video. The RAS increases aldosterone, a hormone that causes the kidney to reabsorb more salt and water, promoting edema formation. The second effect is backward congestion. Because systolic ejection is impaired, blood stacks up into the lungs, explaining why pulmonary edema often occurs first. It can also further back up into the right heart and systemic circulation. Doctors might see a dilated inferior vena cava on ultrasound or dilated hepatic and renal veins. This can lead to edema or, in severe cases, ascites through secondary portal hypertension from right heart failure. Moving to the kidneys. Both acute kidney injury and chronic kidney disease, especially when reaching end-stage renal disease, can lead to edema through RAS activation. Additionally, in nephrotic syndrome, there is massive albumin loss called hypoproteinemic edema. A loss of albumin reduces colloid osmotic pressure in the vessels, which also activates the RAS. Leg edema is also typical for kidney disease. Periorbital edema is typical for nephrotic syndrome, and in very severe cases of kidney disease, ascites can also appear. The third organ is the liver. In liver cirrhosis, there is a similar mechanism with RAS activation. Cirrhosis typically leads to ascites through portal hypertension. You can check out our video on portal hypertension and ascites to learn more. In liver cirrhosis, there is also an albumin deficiency, but here it is due to impaired synthesis, because cirrhosis reduces protein production in the liver, where albumin is normally made. So, saltwater edema develops mainly through increased hydrostatic pressure from venous congestion, through RAS activation, and albumin deficiency. There are two other important causes to consider. The first is lipedema, where lip means lipid or fat. This condition primarily affects women, and hormonal causes are suspected. Typically, the thighs are affected, while the feet are spared. Lipedema is also painful to pressure, unlike classic saltwater edema. But here's the key: both are pitting, though lipedema quickly rebounds because it consists of fat. Another type of bilateral edema is myxedema, which results from increased TSH receptor stimulation in long-standing hypothyroidism or in Graves' disease, which is an activation of TSH receptor through autoimmune process. It leads to deposition of proteoglycans in tissue, which are non-pitting edema. And this means myxedema can be recognized because it does not pit when pressed. Now let's talk about local or unilateral edema. First, there's inflammatory edema. A typical example is cellulitis, which is a bacterial infection of the skin, showing the cardinal signs of inflammation. They include edema, redness, warmth, pain, and possibly functional impairment. There are also non-infectious inflammatory causes. Deep vein thrombosis is one, where venous occlusion leads to blood stasis and inflammation with redness and swelling. Another example is gout, which typically occurs at the big toe joint, but can spread to the skin as well and sometimes be difficult to distinguish from cellulitis. Another form is lymphedema, characterized by impaired lymphatic drainage, usually due to compression of lymphatic vessels, for example by a tumor. When lymphatic uptake backs up, increased pressure develops in the interstitium. Typically, the toes are also affected, and no skin fold can be formed because the skin is so taut. This is called Stemmer's sign. And the last form is angioedema, which is a local allergic or anaphylactic edema in response to an allergen. There is a strong vasodilation due to histamine release from medication intolerance or contact allergy. Let's summarize today's topic. First, edema is classified as pitting or non-pitting. Saltwater edema from heart failure, kidney disease, liver cirrhosis, and nephrotic syndrome is typically pitting, whereas mixed edema is non-pitting. Lipedema is technically pitting but rebounds quickly. Second, the most common cause of bilateral edema are heart failure, chronic kidney disease, nephrotic syndrome, liver cirrhosis, or medications. Third, unilateral edema is most commonly caused by deep vein thrombosis or cellulitis, or it might be lymphedema. Fourth, RAS activation is a central mechanism in many forms of bilateral saltwater edema, leading to sodium and water retention in the kidney. And lastly, lipedema typically spares the feet and is painful, whereas lymphedema typically involves the toes with a positive Stemmer sign and is usually not painful. I hope this video was helpful. Consider subscribing, and I'll see you in the next video.